Good evening to present the session. Assalamu alaikum, Zishan.
Sound, sir.
So we are all set. Sharif, are we all set?
Yes, sir.
Can we run? Hi, good evening, and welcome to the second webinar of the fifth module, which is on advanced kidney cancer. This module is essentially focusing on three talks. The first one by myself on impact of ERAS in the kidney cancer surgery, and this will be followed by a talk on role of cytoreductive nephrectomy in metastatic renal cell carcinoma by Mr. Zishan Aslam. And the last talk of this evening is by Professor Syed Anwar Hussain, which you all know very well, and we have the pleasure of listening to him about systemic chemotherapy in cases of muscle invasive bladder cancer and upper tract urothelial cancer. So this will be followed by the third webinar of module 5, which is focusing on some interesting cases in the MCQ and genetics of the kidney cancer. So I'll be talking about impact of ERAS in kidney cancer surgery. We know that ERAS is very well established for at least two major urological procedures, which is radical cystectomy and diversion and RPLND for testicular cancer. However, its role in other urological cancer surgeries like renal cell carcinoma is relatively less established. So we're going to focus on the impact of ERAS in kidney cancer surgery. I have no conflict of interest related to this presentation. We know that kidney cancer surgery is a complex surgical procedures which include partial nephrectomy for small localized kidney cancers, particularly for T1A disease and sometimes also T1B cancers, to radical nephrectomies, which is for larger kidney cancers, and then advanced kidney cancer surgeries, which is for patients who have locally advanced disease, and also for patients who've got IVC thrombus, which can be from level 1 to level 4. Majority of the upper tract surgeries, including kidney cancer surgeries, are now performed by minimally invasive surgery, which includes both laparoscopy as well as robot-assisted surgeries. Laparoscopy is perhaps still has a significant place in urology for kidney cancer surgeries. However, open radical nephrectomies and partial nephrectomies have a very clear definitive role. It is particularly for difficult partial nephrectomies, very large kidney cancers, and patients with IVC thrombus are preferably treated by open surgery rather than by minimally invasive surgical technique. An ERAS protocol is equally applicable to both. Generally, people think that it is only for patients who are undergoing minimally invasive surgery, but that's not true. Well, the initial workup is important, and it is important to identify the pre-existing conditions, determine the ASA status and the Charlson Comorbidity Index. It is important to optimize your patient for the selective surgical procedure before undergoing this major surgery. It's important that we line up the anesthesia evaluation. Nurses are a very important component of the implementation of the ERAS protocol, it's also important to involve GP. However, it varies in various countries how GPs interact with the main hospital performing these complex surgical procedure. Dietitian is again a very important component, and diet is important both for ERAS protocol and post-operative recovery. Physiotherapy, particularly the chest physiotherapy, and also mobilization of the patient is something that we need to be cognizant of and take necessary steps. All these things should be under rigorous quality checks to make positive changes so that the protocols can be changed according to needs. So there's not one protocol which is equally effective throughout various healthcare system. Preoperative counseling is also important in the ERAS protocol, in which you need to talk to your patients about cessation of smoking, for example, about the anticoagulation preoperatively. The preoperative nutritional status is important and overall healing of the wound. Avoidance of fasting, which is part of the protocol of the ERAS pathway, and we're going to talk a little bit more about this a little later. The carbohydrate loading up to 2 hours preoperatively, as we know, is an established component of ERAS protocol rather than the traditional way of prolonged fasting. The anesthesia should be standardized. The analgesia post-operatively and peroperatively should also be standardized. As early as possible, mobilization of the patient is the most important component, in my opinion, for patients' early recovery. So, in essence, ERAS is 3 major components. The preoperative component that we have talked about, then we have the intraoperative component and the postoperative component. So all these 3 different components are extremely important in achieving the goals of ERAS. So preoperative, as we've talked about, counseling, medical optimization, including diabetes if a patient has one, obviously irrespective of the complexity of procedure, mechanical bowel prep is no longer used. Exercise improve the tolerance of the patient, and ability to heal and get well soon after surgery is extremely important. And some of the centers very strongly recommend certain protocols in physiotherapy and exercise tolerance. As we've talked about, preoperative fasting is something which is now avoided, and carbohydrate loading, which is real opposite of the previous era of surgery, is the way. Epidural anesthesia is something that I personally like to avoid for patients who, for all urological cancer surgery, because in our practice, patients with epidural anesthesia takes at least 2 to 3 days to get out of the bed. And this is really counterproductive. And there are various other ways of controlling postoperative pain that we're going to touch upon a little later. Well, minimally invasive approach is preferable whenever it is possible, but in certain very complex partial nephrectomies, large, difficult radical nephrectomies, and patients with significant IVC thrombi are the one who probably would require preferably open surgical approach. The anesthetic protocols should be discussed, and institutional policy should be made about anesthesia protocol for patients undergoing intraoperative hypothermia should be avoided as much as possible. Postoperatively, the nasogastric tube, if placed, should be removed immediately after surgery before the patient is moved to the recovery room. The urinary catheters should also be removed as early as possible unless partial nephrectomy is done and the patient has calyceal repair in which you would like to keep the intravesical pressure low. The prevention of postoperative ileus is extremely important, and it's one of the major factors responsible for delayed discharge from the hospital. The postoperative analgesia we're going to touch upon a little later. Early mobilization is the key, and early oral diet is again important in preventing ileus-like situation. And you need to continuously audit your practice so in order to improve upon the existing standards. So ERAS has rapidly developed in the recent years. General surgery were the first converts from traditional surgical approach to ERAS. Neurosurgery, colorectal, hepatobiliary, and now urology. In urology, radical cystectomy, radical prostatectomy, and RPLND are the major surgical procedures in which ERAS is an absolute necessity. And now we are seeing that increasing adaptation of ERAS in radical nephrectomy and partial nephrectomy patient. The whole idea is to reduce hospitalization time, reduce the medical expenses and complications after surgery. Now, if you look at the ERAS, we see this is nearly a total opposite of what we've been doing since we are operating and doing major surgical procedures with prolonged fasting, NPO 6 hours prior, which is still practiced for solids. But for clear liquids, it's important that they should be getting clear liquids up to 2 hours prior to surgery. Mechanical bowel preparation is definitely not required. Prolonged nasogastric tube is counterproductive and it causes paralytic ileus. The drains are either not placed at all, but if they are, they should be removed as early as possible. And postoperative bed rest, which was the standard of practice after major abdominal surgeries in the past, is now replaced by early mobilization. Now, a few words about prolonged fasting. The nil by mouth for prolonged periods preoperatively causes discomfort, anxiety, thirst, and nausea in patient. So it's important that we should not keep our patients NPO. In fact, sip till send approach is now more commonly practiced, which means that you take sips of fluid, a clear fluid, even until the time that you're called for surgery, or at least 2 hours before you put to sleep. The carbohydrate loading decreases the insulin resistance and thirst, maintains lean body weight and muscle strength. So it is important that the patient should be on carbohydrate loading rather than NPO. The prolonged fasting, the drinking of 8 to 10 ounces of clear carbohydrate beverages up to 2 hours before surgery is what is recommended now as a standard. The intraoperative management part of the ERAS protocol for nephrectomy include thromboembolic prophylaxis, which is again important. 5,000 units of heparin preoperatively. This is followed by low molecular weight heparin for prophylaxis. Now, personally, I don't use it for longer periods of time. I generally stop it as soon as the patient becomes mobilized. Next day after complete mobilization, stop the heparin or LMWH. But for patients who have undergone major IVC thrombectomy, up to 4 weeks of prophylaxis for chemical prophylaxis is indicated. Fluid management should be optimal. We know that patients who've got kidney cancer are very high risk of developing AKI and subsequent CKD as well. So the fluid management should be really optimal. One anesthetist should use pressors versus crystalloids because they can cause bowel edema and third spacing, which would make patient dry in the first 3 days, and then they would be in the diuretic phase, which is really not ideal situation. And hypothermia prevention, again, is something that we need to avoid. Now, mechanical bowel prep, as I have said earlier, is now outdated. And except for colorectal surgery and colonic surgeries, and where colon is being used by urologist for reconstruction, the mechanical bowel prep is no longer used. So what we do is enema is definitely required, and even antibiotic prophylaxis for bowel prep is also not used. And there is clear data indicating that patients who had mechanical and those who did not have mechanical bowel prep, there was no change in complication. Now, postoperative ileus is a factor which is responsible for delayed discharges from the hospital. The risk factor for postoperative ileus include male gender, advanced age, and major blood loss during surgery. The limited preoperative fasting with solids hold 6 hours prior to surgery, and the clear liquids 2 hours up to surgery is now recommended to avoid bowel-related complications. Most of our patients are advised to take this electrolyte solution, which is used by the athletes. It's really recommended up 2 hours before surgery. Virtually no postoperative fights fasting, therefore. Day one, they start chewing gum. Day two, black tea and maybe yogurt. And day three, full liquid diet. And then you can progress accordingly. So all these factors are extremely important in preventing the postoperative ileus. One of the second most important reason for developing postoperative ileus is the use of opioid. We know that the opioid agonists stimulate the 7-transmembrane G protein coupled with micro-opioid receptor on the postsynaptic neuron. And this initiates steps that reduce the release of neurotransmitters, for example, glutamate, acetylcholine, norepinephrine, serotonin, and substance P, etc., and promote the efflux of potassium, which leads to the hyperpolarization and hence reduced cellular excitability. So in the central nervous system, these actions are responsible for providing analgesia. Whereas these actions reduce the transmission and the blockage of the micro-opioid receptor in the GI tract causes changes in the gut motility and water secretion and absorption that may result in constipation and contribute to the development of postoperative ileus. So in the GI tract, these effects can be blocked by medications called elvimopam. It blocks the binding of the opioid agonist to the micro-opioid receptor and helps prevent constipation. Because the elvimopam does not cross the blood-brain barrier, it would not affect the analgesia effect of the opioid painkillers. The other important component of ileus prevention, besides the use of elvimopam with opioids, one of the problems with elvimopam is it's extremely expensive, and its availability is also an issue with most healthcare systems. It's not available in my country, and I've never used it personally. So there is another agent which is significantly cheaper, which is called naloxegel. Naloxegel is a much cheaper option, and it results in a saving of over $2,000 over a 6-day hospital stay compared to albumin. Now, radical cystectomy managed with the standard ERAS pathway, there were no difference in the post-operative recovery based on the use of albumin versus naloxegel. So these other agent can be neostigmine is another drug that I used quite frequently because of the non-availability of albumin. Chewing gum, as I've said, day one initiates the gastrocolic reflex and is extremely important in starting the or restarting the bowel activity. Besides which standardized bowel regimen should be. One of the most dreaded complications, at least from patient's perspective, is pain. And pain control is something that is extremely important for a patient to be supportive and helping in the overall recovery. So for pain, obviously we have been using oral and injectable agents. However, the use of blocks like tab block is increasingly recognized as a way of avoiding complications related to the oral or injectable analgesics. We know that there are several nerves that supply somatic sensation to the abdominal wall, and they are not really involved in the visceral sensation. So tab block techniques are pretty standardized. These are the various landmarks for doing the tab block, either used on anatomical landmarks or ultrasound guided tab block can be given, and it can also be given peroperatively when you have already done the laparotomy. So besides tab block, use of oral paracetamol and gabapentin are helpful. However, the tab block doesn't work above the umbilicus, and for that rectus sheath block is important, and rectus sheath block can take care of the somatic sensation or pain above the umbilicus, between the xiphisternum and the umbilicus. So rectus sheath block again causes significant pain reduction and helps in early recovery of the patient. Now, what agent should be used? There is data indicating that liposomal bupivacaine, which is not easily available and is also quite expensive, is extremely important if it is available, and because it provides pain control for up to 72 hours, and that's what the post-operative pain, the post-operative pain period is. It can be mixed with lidocaine, which provides early relief of pain, or with clearmarcaine with normal saline, and it is used. Now, before or after surgery is the question. If you use it before surgery, it would not let the pain cycle to initiate, and is considered and provides a stable hemodynamic status as well during the surgical. So in general, avoid narcotics, use topical and local infiltration, and the systemic treatment should be with acetaminophen and gabapentin. AKI is a common observation after kidney surgeries, be it partial or radical nephrectomy. So development of AKI is seen in about 15% of the patient. It is essentially related to the pre-existing body mass conditions like body mass index, history of hypertension, the complexity of the tumor, and if radical nephrectomy is performed compared to a partial nephrectomy. Now, development of clinically significant chronic kidney disease is seen in up to 56% of patients, so development of AKI is one of the risk factors for developing of. It is seen more frequently in patients who have high complexity and intermediate complexity tumors rather than low complexity tumors. So kidney function preservation is one of the key factors to avoid long-term complications. The preoperative evaluation of by a nephrologist is important in selected cases where you suspect that the patient is likely to undergo CKD or develop AKI. The preoperative fluids and electrolyte balance, optimize diabetes control, intra and postoperative blood pressures management are some of the factors by which development of AKI can be prevented. The predictors are baseline EGFR, warm ischemia time, and surgery type. So partial nephrectomy, less radical nephrectomy are more likely to cause these problems. Patients who undergo high level of IVC thrombectomy, which is perhaps a very complex surgical procedure, are at high risk of developing various complications. However, because of the oncological benefit of this kind of surgical intervention, this is often performed, and they are often performed in a open surgical method rather than in a minimally invasive option. In our own experience, in this article published some years back, we look at the outcome variables to show the blood loss, the mean operating time, incision to wound closure time, total hospital stay, and development of various complications. So in essence, the key component of ERAS is perform MIS whenever it's possible, follow the clinical pathway, and have a well-informed patient who can be partner in the recovery rather than just a spectator. It is multidisciplinary. Surgeons, residents, anesthetists, nurses, pharmacists, patient, they're all important component of ERAS implementation and recovery of the patient. So about patient education, the EAU guidelines clearly states that counsel patients about cessation of smoking. Shared decision making is important to avoid unnecessary expectations after surgery. ERAS protocol should be implemented. Cigarette cessation, preoperative optimization, medical, physical, and mental is all important, and motivation of patient undergoing major surgical procedures. Now, hospital volume and component in decreasing the risk of complications after nephrectomy patients is indicated by this report, in which they've shown that the surgical volume of the hospital have a positive impact. We know that robotic surgery is becoming increasingly common, and after the successful implementation of radical prostatectomy and then radical cystectomy, radical nephrectomy and radical partial nephrectomies are also becoming standard operating protocols. Now, ERAS for kidney cancer, the objective is to facilitate accelerated recovery, optimize recovery, shorter hospital stay, fewer complications, and improve patient experience. You need to engage the team, and they should be positively contributing in the patient's recovery and the patient himself. motivated enough by pre-operative counsel will be a much better patient than uninformed patient. Well, we live in a very desperate world. It is the healthcare system varies in various institutions and across the countries. It could be the resources is an issue. However, you need to have a clear goals, and the objective is to have as low complication rate as possible, quicker and earlier recovery of the patient, and a good experience patient after surgery. So to achieve these goals and to reach your destination, you can use a safari or you can use an old car. The whole idea is to reach your goal. And
Okay, thank you very much for patient listening. You can post your questions on the chat box and we will try and address them. In the meantime, I would request my dear friend Mr. Zishan Aslam for his presentation on cytoreductive nephrectomy for metastatic renal cell carcinoma, an extremely important subject, uh, especially in the era of effective systemic therapy. So, Zishan, the podium is yours.
Thank you very much, sir. Thanks for the very useful talk. Right, so my screen is visible and you can hear me, everyone?
Yes, loud and clear, and we can see
Yeah.
the slide.
No, thank you very much. Very useful talk, sir. Thank you very much for that. And these are very important topic in dealing with metastatic kidney cancer. And really looking forward to Professor Hussein's talk as well later on. And hopefully that will really uh, kind of add to what I would try to teach in the next 30 minutes. So it is about cytoreductive nephrectomy for metastatic kidney cancer, which has been a subject of much debate over the last 2 decades with clinical trials going on. And often colleagues, I've heard them saying it, especially oncology colleagues as well, that it to some extent it still remains like an evidence-free zone. We do have some answers, but still there are things which are unanswered, and a lot of time some clinical sense needs to be implemented while selecting the patients for these. So as you must have gone through all these during your curriculum and your studies, that it's a dangerous disease with 15 to 30% of patients presenting with metastatic disease, and at the same time previously treated patients, surgically treated patient, they would have about 30% of them will go on to develop metastatic disease. So we are dealing with a lot of metastatic cases in this disease. Risk stratification wise, there are two criteria. One of them is MSKCC, Memorial Sloan Kettering, which takes into account performance status and certain blood counts, hemoglobin level, calcium, LDH, and time for diagnosis to treatment, less than 1 year. When you come across a patient presenting with metastatic disease, these are the things that you use to risk stratify them, which leads us further to further decision making. And patients with no risk factors, just have metastatic disease, they go into the group of favorable disease. Those with greater than two risk factors are the poor prognostic group, and those with one to two risk factors, they are intermediate prognostic group. And when we talk about cytoreductive nephrectomies, to me, this is the group where all the debate is about. And obviously, hopefully, in the next 30 minutes, I will explain a bit more about that. That which group among intermediate would be best serves, and that's where evidence is there, but not so conclusive. And at times we have to analyze it in our own ways. So this is a risk factor model, and you can just see that three, four, or five risk factors, the black dotted line, how poor the survival is. in from a time from starting interferon, which was the historical SAC treatment, systemic anti-cancer treatment. And whereas in one risk factors, the median survival still was about 20 months. Another criteria which is more commonly used these days is IMDC score, International Metastatic Disease Consortium score, also called as Henge criteria, after Dr. Henge, who had some years back developed this. It's more or less to MSKCC as well, taking into account performance status. Blood counts are slightly differing in terms of platelets and neutrophil counts, but more or less it's the same. And so this is what we have been implementing more recently to risk stratify and then make further decisions. So this is based on an IMDC database consortium. The survival was seen in these three different groups: favorable, intermediate, and unfavorable, and using first line and second line systemic treatment. And it was again found that the unfavorable, the poor prognostic group, had very poor survival, and intermediate group had survival, which could be varying between 18 months to 2 years. So this was just to give you an idea about how lethal the disease is. So cytoreductive nephrectomy, role of surgery in metastatic RCC. There are three different categories of that. One of them is cytoreductive nephrectomy, and this is mostly indicated in brief with patients with good performance status who have resectable disease, and majority of the disease is within the kidney. And mostly these patients are ideal candidates for cytoreductive nephrectomy, and after that they go on to systemic therapy, and in some cases simple observation if let's say a patient has got one or two small lung nodules, just as an example. Consolidative nephrectomy, again, it is a cytoreductive nephrectomy, but the name for that is slightly different because this is a case where we start with systemic therapy, and that's more common in patients who have bulky metastatic disease and potentially unresectable disease, and where the tumor biology is slightly unclear regarding how they would behave in terms of our treatment options. So they go on to have systemic treatment, and when they have good response, then as a joint decision in the tumor board's meeting, in the urological MDT meeting, we can decide to remove the kidney at that point. And we will see a few cases of that later on. And the final concept is metastatectomy, where we just simply removed solitary or oligometastatic lesion as long as they are resectable. Complete resection is usually one of the indications for that. I mean, if someone has got lung mat and liver mat, then there's not much point in removing one of the mats and leaving the other. If you are going after the metastasis, then you should be able to remove all of them. And then patients go ahead to have systemic treatment and sometimes observation. Well, they start with systemic therapy, then metastatectomy. And after that, systemic treatment or observation, if let's say patients have a period where they're totally disease-free, despite that they are a case of metastatic kidney cancer. So we'll go a little more into detail of cytoreductive nephrectomy. So this concept has been going on for decades, but the two landmark studies was done towards the end of last century, published in New England Journal of Medicine and Lancet. And one of them was Southwest Oncology Group study, an American, and the other one was European. And these were done using the immunotherapy agents, which are historical, and we don't use them. During my years in urology, never seen them. And what my senior colleagues have always taught me is that they were a lot more toxic than the current systemic treatment regimes. And both these studies have suggested survival advantages in metastatic group of patients or patients who had cytoreductive nephrectomies. So while choosing patients for cytoreductive nephrectomy, I mean, well, unfortunately for the patient, and in a way, fortunately for me, I worked in a center which was a moderate volume center in Nine Wells Hospital. But despite that, we had quite advanced diseases presenting there. So I get to do quite a fair bit of these procedures. And the factors that we have to consider, or I would consider as a matter of time, is first to keep in mind cytoreductive is not a risk-free procedure, right? It's not. It may be more complex than a standard nephrectomy, and I think in the laparoscopy talk at the last session, I may have stressed on that they have more desmoplastic reaction, they have more angiogenesis found, and they are generally slightly bigger masses. Metastatic cases generally have higher perioperative morbidity. It could be related to the cancer-related cachexia, anemia, coagulopathy, and many of them have paraneoplastic syndromes. And surgical complications, why we worry a little bit more about here is because these patients are going to go on to systemic anti-cancer treatment after that. SECT. If I keep using the word SECT, this is what it means during the talk. And we don't want to delay that because that's where it could be detrimental. But a question which often we ask is that could SET be more morbid than surgery in fit patients where your procedure goes well? And this is not something which is my personal opinion. Often I work with oncology colleagues who often uh, have these opinions as well, that so many patients, if they have cytoreductive and does not have a large metastatic load, then they can just avoid or delay SECT as much as possible. And often in clinical trials, it has also been noted that the morbidity in the CRN arm, it could be related to the SECT delivery as well, which the patients went on to receive after that as well. So these are the things we have to balance about oncological care, but keeping the same time that we are not increasing the morbidity because of the surgery, which will delay the treatment and have harmful effect in terms of oncological benefit. So we'll look at few historical studies. So this study was again in the previous era before the modern cancer drugs, where they have defined the group with where you can achieve 75% debulking of tumor. For example, someone has got 8 centimeter renal mass and has got um, lung and lymph nodes, which could be over less than 2 centimeter overall, then we that's where we are achieving significant debulking. One of the things were no CNS, bone, or liver metastasis. These are the groups which were not shown to benefit in the time. I can speak about bone in this era. If there's isolated lesions, then they often could be combined with radiotherapy. And I'm sure Professor San will teach us a bit more about that. So this was a study which suggested that the group that they had dealt with had 77% developed disease progression, morbidity and mortality, and patients uh, had did not have further systemic treatment after that. And overall mortality rate was 17% as well. But all these patients, they were performance status 1 or higher, um, which means they were not the fittest patients. MD Edison, which has published most in the historical era about these patients with stage 4 T4M1 disease, and has suggested that again this procedure carried with a significant morbidity and in terms of overall blood loss um, and recovery from the surgery. So at that point, it was the survival benefit was slightly unclear. And prognosis in that group, that advanced group, is generally poor. And this is something which we know and practice pretty much in this era as well. This is something again which applies in the current era as well, that patients who have just lung metastasis, they do better than bone or multiple sites metastasis. Um, and those who have more than one organ site was associated with poor prognosis. And generally, with multiple sites, even in the current times, we generally don't proceed with cytoreductive nephrectomy. So this is just a review article, if anyone is interested, where I had summarized all this historical data, and that was a time I'd written with Phil Matthews, who was very experienced in a surgeon when Carmina trial had started in 2010, 11. So we have seen a rapid expansion in the various anti-cancer drugs in the last 2 decades, which has really opened and broadened horizons for us. And uh, and the most common ones are VEGF and as well as the immunotherapy drugs. And several randomized trials, well, not several, the randomized trials have going on in the past. And the most famous of that was Carmina trial, which looked at the role of nephrectomy in patients with metastatic kidney cancer, which was treated with sunitinib only group versus cytoreductive followed by sunitinib. So this was a non-inferiority trial where the objective was to see whether sunitinib alone is more than enough. So this trial had 450 patients enrolled over 8-year period, and I think follow-up was about nearly 4 years. And the results were in the red font is that sunitinib alone group was non-inferior to those in the nephrectomy with sunitinib group with regard to overall survival. And there was no significant differences in response rate or progression-free survival where they were observed. So what was the conclusion of a study? That sunitinib alone was not inferior to surgery plus sunitinib in patients with intermediate risk or poor risk disease. And instantly in 2018, the message that was often taken from this group, from this study was do not do cytoreductive nephrectomy. And as a result, PAUS has started its own audit in 2019 about cytoreductive nephrectomy, just to further evaluate these findings, the results of which I don't think we had ever received, whether it was completed or not. I don't think so. So the question arises after that is, would I still do it and when? And that's where it is very important that for such a study, which is it's a brilliant trial which went on for almost a decade, but it's important to knowing and having the analysis of the evidence. Knowing your own practice and results is also very important because cytoreductive it's never been a very common operation in terms that there will be thousands and thousands of operations going on. So it is very important to know your own practice and seeing the patients on an individualized basis as well. Knowing the oncologist practice, and this is the biggest pleasure of working when you have working with oncology colleagues because they have more kind of month-to-month experience of dealing with these patients. And a lot of time, their own judgment and clinical sense really helps. And if you're working with a colleague like that. So clinical judgment is again the same points I had mentioned. There's focus on what needs to be eradicated, whether primary tumor or the metastasis, which means it's the bulk of the disease in the primary tumor. I often also think for low risk disease, can I avoid the sect altogether or delay it? And again, for intermediate, same point is the disease bulk is going to be removed because this is the group which was included in the Carmina trial. So this was a study when I talk about analyzing the data. This was after a Carmina trial by Robert Moser, the MSKCC group, who has done a bit of analysis of Carmina trial that it's a brilliant trial, absolutely very useful, but the recruitment has been slow and only 450 out of 576 planned patients were included. And they mentioned that only in MSKCC, they do 24 cytoreductive or 25 annually. And also picked up that nephrectomy group had more T3, T4 tumors and 70% compared to 50%. So the disease, the cases that were included, they were aggressive to begin with. And of course, just like many other trials, there was some contamination. If I add a bit more to this, then clearly less recruitment means reduced statistical power. Now, this was a French-led study, and the cases recruited were less than 50 per year. In UK, we do about 300 cases per year. So it means a lot of cases were missing from the study, and could they be the cases where cytoreductives benefit most? The patient in this group also in this study, poor risk for about 41% and metastatic burden was 38%, which means to start with, they were very aggressive disease who may not benefit. And low risk disease was not included. And then there were certain number of patients who did not have T stage and nodal state recorded either. So the point come is that that we come to is that low risk cases were not included. However, we already pretty much know the answer that these are the patients who would benefit. The high risk group, we again know the outcomes that they do not do well with this procedure and have poor outcomes. So basically, what Carmina trial had done is by not including low risk group, which I don't know was intentional, but we already knew the answer. And again, with the high risk group, they have further validated this and reinforced our practice that these patients do not do well. So that's why I kept on saying that despite some weaknesses that many analysts have mentioned, this trial was still very useful in validating our previous understanding. So again, the question comes to the intermediate risk group, as I said at the start of the talk, that it is mostly the intermediate risk group where the debate is mostly about. But but Carmina trial has mentioned about that even in intermediate risk group, this procedure is not beneficial. So a further meta subgroup analysis has been done on the Carmina trial, which was presented at ASCO in 2019. And this is something which is adopted in guidelines now as well, that patients who are intermediate risk group and had one factor IMDC, as well as only one metastatic site, they may still benefit. So rather than having several of those IMDC or MSKCC criteria positive, let's say if only their hemoglobin was low than the value which is than normal value, and only they have lung mets, yes, patient still falls in the intermediate group, but they could still benefit. And delayed nephrectomy after initial in good responders, that was also found to be associated with longer overall survival. So this has not completely ruled out cytoreductive in intermediate group in like a subgroup of intermediate risk disease. So I'll go through some of the cases of my own with permission. That this is a patient who had intermediate risk disease. You have seen the mass. He had two lung nodules. One of them is visible to you on the left side of the chest in the periphery. And he went ahead to have cytoreductive nephrectomy. After the surgery, he had a good recovery. No sac was needed. Incidentally, lung nodules disappeared, which is again a phenomena we sometimes notice in metastatic disease. That after removing the disease bulk, and this is one of the concepts behind cytoreductive, that after removing the disease bulk, there's whatever the immunogenic factors or the disease driving factors are there, they are not there. So sometimes very tiny lung nodules could disappear. This is another lady who was 53, high BMI lady, 9 centimeter mass, and this solitary rib mat you could see, intermediate risk disease. And historical era has suggested rib metastasis, bone metastasis. We don't recommend that, but she went on to have cytoreductive surgery and no post-op issue. Now, surprisingly, it was a G2 disease only. Post-operatively had radiotherapy to the rib metastasis and no SAC was required. And the last follow-up that I had, because I had changed the hospital, she had no recurrence. She was stable post-radiotherapy appearance of the rib. There's another patient who was a little bit more aggressive disease of a renal lesion as well as humoral metastasis, which had a pathological fracture and bilateral lung nodules, had excision of humoral lesion from the trauma team because of the fracture. And they had cleared up the disease for this patient. And then we did a laparoscopic nephrectomy, which was a very aggressive disease, G4PT3A. So lung nodules gradually increase and very quickly he went on to pembro and axitinib with good response, but developed acute hepatotoxicity. It was started after a break, developed intra-abdominal sepsis, diverticulitis, and then at that time it was just a stop and he has been on surveillance for another 1 year with stable lung nodules. So this is a case where if we did not have cytoreductive done, then at this point, oncology and urology could have coordinated, and he could have a consolidated nephrectomy done, or looking at the other way around, he had a cytoreductive done. And this is just an example that in cases with a very small lung volumes, surgery could be less morbid, and then patients can observe for as long as they can. So that's where I say small number procedures, knowing your own practice, and individualizing risk and benefits for these patients. So with that, we will slightly move on to consolidative nephrectomy, which was comparison of immediate versus deferred cytoreductive nephrectomy, called a CERTIME trial. Unfortunately, CERTIME trial was designed to investigate that, and it was only clear cell cases and intermediate risk disease. What it suggested at longer overall survival with deferred nephrectomy than with consolidative nephrectomy compared with cytoreductive, that is upfront radical nephrectomy. But the study was thought to be underpowered, and it has closed early. There were only 99 patients. So any observation from this study could be hypothetical. But again, there is a way to look at this. Yes, it may have suggested that patients who had consolidative is better than upfront nephrectomy. But at least it is giving me a thought process and this idea that consolidative nephrectomy is a very useful concept as well once patient go through this anti-cancer treatment and get the disease under control. And for that, we will again see a few patients. This is a patient who had been started on cancer drugs presented in 2020, and this was discussed towards end of 2022. He was on second line, and his response was not the best. And if you see in this picture, you can see this is the primary mass. There were a few lung nodules, and this is a subcutaneous mass. They were just static, and our oncology colleagues were of the opinion that the patient may benefit from consolidative nephrectomy because he was kind of moving towards third line now. So we had done cytoreductive nephrectomy consolidative cytoreductive nephrectomy. And since then, he has been continuing with SAC treatment. And I had taken some information about that recently, that he has a stable disease. The concept here was that without cytoreductive, could his disease has continued to progress or not? We don't know the answer, and that's where it is often said that we are still in an evidence-free zone, and that's why individual patient we have to have certain approaches and see whether that could give the maximum benefit to this patient. So this is another 53-year-old lady who had metastatic cancer T4N1. And you can see there's a lung nodule at the top. And she had a pretty locally advanced disease. It was a T4 disease, as you can clearly see here. Lots of lymph nodes and a big cancer. So she was on SAC treatment. She had a very good response. She had a very good response, and all her lung nodules were disappeared, and her regarding all the mass had disappeared. So she had consolidated nephrectomy, and she's still on maintenance exitinib. I just wanted to show you the picture when we decided to do cytoreductive. This one. So the lung nodule had disappeared by that time. And you have seen the very locally advanced disease already. And you can clearly see that how confined the disease is now. All right. So we did cytoreductive nephrectomy on this patient. And if I remember correctly, this is the case which I had to open because it was such a intense reaction there, desmoplastic reaction. And she's stable on maintenance exitinib. So in conclusions, both trials have limitations as well. Both trials have patients with high metastatic volumes, and these trials should not be used to abandon cytoreductive or consolidative. Patients who benefit most are a good performance status in favorable risk disease, intermediate risk patients with low metastatic volume, where you can remove the disease bulk, and to further subgroup it, that is single site metastatic disease is what we mean, and patients who have single factor IMDC intermediate risk. Patients who are good responders with SAT, they can go on to have consolidative nephrectomy as well, again on individualized basis. So these are guidelines, EU guidelines, which do pretty much talk about the same. Strength rating remains weak for most of these. Thank you very much.
Thank you, Zishana. Very comprehensive talk, and thank you for sharing your personal experience as well. We know that in terms of high quality evidence, if we put our real life situations, we mostly find ourselves in the gray area where either decision can be taken. We are very fortunate to have today Professor Anwar Hussain, and we had the pleasure of having him in the bladder cancer as well. And Professor Hussain is going to share his vast experience in dealing with this situation. He's going to talk about what agents, how to use them, and what protocols for slightly less intellectual people called urologists. Thank you very much, Professor Hussain.
Thank you very much, Ahmad. That's so kind of you. I really, I'm just trying to set this up now. How can I share my screen? Can you see my screen at all?
Not as yet, Dr. Hussain.
Okay. Do I need any permissions or something? Because it just should have taken in.
No, you are the host, so you should not have any problem with permissions.
Okay, let me.
So maybe you can unshare and then share again.
Ahmad, I will just leave and come back. It's asking me to leave and come back to join.
Sure, Dr. Hussain.
Just one second.
Yes, we can see it.
Thank you very much. No, it was a real pleasure hearing your talk, Ahmad, about enhanced recovery. A lot of many years ago when I did any surgery, so a lot of memories with that, and really great to understand how things have moved. Really, always wonderful to hear from you. I heard your talk about robotics previously as well in one of the bladder sessions. It was a great treat. And again, Zishan, thank you very much. Really, I think in terms of cytoreductive nephrectomy, this is a huge area of research, and I think you've covered quite a few things, which was very helpful, and I will build on that. And I think one thing to remember, and just before I start my talk, because I will be talking about systemic treatment, I think it's worthwhile to talk to my surgical colleagues that this field really requires more research. I think in the era of immune checkpoint inhibitors and IO plus TKI, this is an area of untapped what we can achieve, and especially the number of cases you do in Pakistan. And if you develop some sort of a collaboration, that can make a big difference. And you can develop a trial of your own coming from Pakistan, because all the data on Carmina and most of the data is really pre-IO sort of era. And there was a paper just a couple of weeks ago, which I had seen in European Urology Oncology. That was a Dutch series of about 800 plus patients. Very small numbers went into upfront cytoreductive nephrectomy with the IO, but they did well actually. So there is, in randomized trials are required, but before randomized trials comes in, proper selection of patients, and then using basically cytoreductive nephrectomy. And again, as we talked about, perhaps again, diverging from my own topic, but because it was such an interesting topic and it's a weekly debate in our MDT, and I always prefer that cytoreductive nephrectomy for those cases which have a big kidney tumor with a small volume lung mets, for example. So there is visceral mets. Similarly, when I discuss with my colleagues in Pakistan and other places, sometimes when you've taken the deep bulk of the tumor out, many of these patients do well. So that was literally to just talk about some of those factors, but we'll be very happy to take questions as we go along. So this is what I will be talking about in the next 25 minutes, 30 minutes. These are my disclosures. So again, from our urology colleagues' point of view, it's really important to know what our strengths are, how things are moving, where we are today. And I think it is really important to understand that actually in terms of the survival benefits and things, there are a huge number of patients who are getting kidney cancer worldwide. 80% of these patients with RCC are of intermediate and poor risk prognosis, so they do not do very well. 47% of patients never go on second-line therapy. This is important because it is telling you that your first choice is important. What do you do for these patients? So these are the patients with metastatic kidney cancer who are not amenable for surgery, and the first-line treatment you are using. And the reason is that some of these patients will progress very quickly on treatment, and some of these patients will progress while waiting for treatment. And that is why it is important as diagnostic clinicians, as the urologist, I always call you the gatekeepers who see these patients first, are involved in their diagnostic pathway. It makes a big difference when it takes 6 weeks or it takes 3 to 4 months before the patient comes over. There is a huge difference in terms of patients' morbidity and things as well in those 6 to 12 weeks. So it's important to diagnose them. And improved overall survival and greater durability of response remains a goal. That's what we are achieving here. TKI era was there, where we were seeing sorafenib, pazopanib, sunitinib, bevacizumab, interferon, everolimus. So a lot of these things were there, and there were a lot of trials there. Sunitinib versus interferon, bevacizumab, pazopanib versus placebo, cabozantinib versus sunitinib, temsirolimus versus interferon. All of them were giving you some responses. The median survival was going into 2 years. And that was a big gain. Remember, 20 years ago, we were really struggling with less than 12 months. So things were moving. And then came the immunotherapy era, which is immune checkpoint inhibitors. And you had nivolumab, nivo-ipi, nivo-cabozantinib, pembroaxitinib, lenvatinib, everolimus, cabozantinib, avelumab plus axitinib, tivozanib, pembro plus lenvatinib. So all of that is really, really interesting because what it is telling you is that the arena has completely changed and you're seeing survival, which is significantly more. Why it is so important, why I said that it is key when you are diagnosing these patients, they are being referred earlier for a discussion in the MDT. If patients can have cytoreductive nephrectomy, is it worthwhile, or they go straight to systemic treatment because there's no point because there's quite significant metastatic disease load. Remember, in 2005, we're talking about median overall survival of 12 to 15 months. This was pre-TKI era. Then came the TKI era with 24 months, 36 months. And 2015 until now, we are now moving into 4 years and more. And this is really significant, big gains that we have achieved through very multidisciplinary team working, where urologists, oncologists, radiation oncologists, everybody has worked together to get the best for our patients, and palliative care teams, our pharmacy colleagues, nursing team, all of us have worked together in improving the outcome for these patients. Because many of the new agents like immune checkpoint inhibitors have immune-mediated toxicities as well in small subsets of patients, but identifying those toxicities are important. And treating them and managing them early is key. The reason I want to emphasize it today in front of the urology audience is because you will start to see the use of immune checkpoint inhibitors much earlier. I think Zishan talked about some of that, whether pre or post, whether debulking nephrectomy could be deferred in a setting where you can have nephrectomy. But also in other disease settings, when you're treating bladder cancer, for example, things are moving into non-muscle invasive bladder cancer, which is in your arena. So all these things will mean that we need to understand immune checkpoint inhibitors and their toxicities more and treat them early. But overall, moving into survival of 4 years plus is a big achievement, considering 20 years ago we were at 12 months. Zishan has talked quite a bit about that, which is very helpful. So I just want to mention that these are some of the parameters on which you can look at the prognosis and the biology of the tumor itself and plan your treatment accordingly. So Heng's criteria, IMDC, which is the International Metastatic Renal Cell Carcinoma Database Consortium, all that tells you that if it's a favorable prognosis, intermediate prognosis, or poor prognosis, the outcome is very different. So in a favorable 43.2 months, intermediate 22.5 months, and poor is 7.8 months median survival. So, and again, what are the factors? 0 risk factor, favorable, 1 to 2, intermediate, more than 3, poor risk factors. And the risk factors you look at are quite objective. You look at Karnofsky's performance status. That is the only one which is a little bit subjective, but otherwise hemoglobin, time from initial diagnosis to treatment, less than 1 year, corrected calcium, platelet count, neutrophil count. So all of these give a score. And then if your risk is 3 or more, then you will be in the poor risk group. Where we are moving to, I think one of the key debates, which really I think we need to talk about, is IO, use of immune checkpoint inhibitor plus immune checkpoint like Nivo-Ipi, or you use VEGF plus IO. And then pembrolizumab, axitinib, Nivo, cabozantinib, pembrolizumab, lenvatinib, avelumab plus axitinib, multiple different combinations you have. What are the pros and cons? Always think about. If you use Nivo-Ipi in the first line, you've got some of the second line axitinib, cabozantinib, and other drugs there. When you have used that as first line, you always think about what will be your second line treatment afterwards. But remember that many patients do not receive second line treatment. That's why your choice of first line is going to be key here. In terms of the checkmate study, looking at IO plus IO, nivolumab, and ipilimumab, treatment until progression or unacceptable toxicity versus sunitinib. So all these trials had the standard of care arm was sunitinib in all these trials. So I won't go into too much detail, but I think it's just important to see how things are. Overall survival at 8 years was 33%. And that is something we could not have thought about 20 years ago, that 1 in 3 patients with metastatic kidney cancer will be alive in 8 years. So we are seeing some of these patients who have got advanced kidney cancers who come to us and say, have I been cured? Because their disease we treated 5 years, 6 years ago. We told them there is about 12 months, 24 months median survival, and they are with us at 6 years and 8 years. And looking at that numbers, there is a subset, so 1 in 8 patients versus 1 in 5 patients with sunitinib. How patients post sunitinib are doing well. Again, remember the data that actually many of these patients then are exposed to immune checkpoint inhibitors afterwards. So those who are on sunitinib arm, they can get afterwards salvage immune checkpoint inhibitors, or IO plus IO, or second line TKIs as well. So multiple new treatment options are there. And that's why more and more focus is moving towards disease-free survival, because we know sometimes to get overall survival, you will need, because of the drug availability for those sort of patients in that part of the world with second line IO and other drug options as well. It is important that now when you design a trial, you think about your primary endpoint very carefully. But it's just useful to see 46.7 months median overall survival versus 26 months for sunitinib. So really big gains you're seeing with all these new combinations. So if you look at the IO-TKI combination, Keynote, for example, pembrolizumab plus axitinib versus sunitinib, or Checkmate, Nivo-Cabo versus sunitinib, or Clear, which was lenvatinib pembro, or lenvatinib everolimus, or sunitinib. What is important here? Keynote 426. If you remember a few years ago, I'm sure many of you would have been at ASCO, where it was presented in a brilliant presentation on hazard ratio of 0.54. But as the data matures, you see a couple of years ago when it was presented again, the median survival, the hazard ratio turns into 0.84. And because the sunitinib arm the survival starts to merge or improve because those patients have been exposed to second line IO and other treatments, and that does salvages them and helps their survival. So some of those factors I wanted to say, that when you look at the data, always look at long-term follow-up as well. So for many fellows, and again, the more you look at those papers, how data matures, how survival matures, is that survival benefit still maintained? And always think and dissect that data. Checkmate, Nivo, Cabo, again, is one of the very much recommended regimens that is used, and that is based on, because you've got VEGF, which normalize the vascularization. You've got AXL inhibition, which promotes antigen presentation. So in a sense, you're changing the microenvironment as well. That's the thing between IO plus TKI. Any TKIs you're using, you're changing the microenvironment. And with the Cabo, again, MET inhibition as well can play a role as well. So with all these sort of combination treatments, progression-free survival, again, looking at overall survival as the secondary secondary endpoint, and overall response rate and quality of life are quite key in these cases. If stratification factors were there, again, like any other randomized trial, you would expect that this will be very well balanced. And it was. What was interesting was that your progression-free survival doubled, 8.4 versus 16.4 months, with a hazard ratio of 0.58. 24 months, 20.7 versus 37.4% PFS, 11.5 versus 20, and 4 years as well. So you can see that some of these patients are maintaining their complete response, and they are have not progressed for quite a long period of time. And that is looking at favorable risk, 1.4 versus 12, and in intermediate poor risk, 7.1 versus 15. So literally doubling in all categories of these patients. Overall survival, 36 months versus 46 months with a hazard ratio of 0.77. And again, looking at 24 months, 36 months, 48 months, you're seeing 48.9% patients alive. And as you go into, as I said, the more the data matures, then you start to see whether this benefit is maintained. Remember, many of these patients will have competing mortality risks as well, and they may not die of metastatic kidney cancer, but other related comorbidities as well. Look at the response rates. So intention to treat, if you look at overall response rate, 55.7% versus 27% in ITT. Favorable risk, 66 versus 44. Intermediate risk, 52 versus 23. Durability of response and duration, you can see there's a significant benefit in those terms as well with the use of cabozantinib and nivolumab. So consistently, you are seeing benefit of IO plus TKI in these sort of combinations. The outcomes, whether there's a liver mets, again, liver mets and bone mets are those where we really feel that there's not much point in going ahead with any nephrectomy. And again, you can see their outcomes, progression-free survival, but still then the benefit was there, 10.9 versus 6.2, 13.8 versus 4.4 in bony metastatic disease. And with lung mets, 8.3 versus 16.4. So again, if you look at the lung mets, sunitinib 8.3, sunitinib with bone mets 4.4, and that tells you that, you know, lung mets, if the patient has to have a mets, lung mets is the better one than liver, and the bones are the worst one in these metastatic kidney cancers, and unfortunately. So overall, you can see that there is survival benefit, which is significant with this combination of IO-TKI. Toxicities are important, and I think this is really key to see what are the risks in terms of toxicities, what is the impact on quality of life. You can get some hypertension, but that you get with TKIs as well. But there are certain factors like transaminitis that can be increased in the IO-TKI arm, which could be immune-mediated hepatitis. So rash or skin toxicity can occur more in that as well. So there are sort of a class of side effects that will happen with sort of immune checkpoint inhibitors as well. Quality of life factors are key, and actually did say that in terms of these patients, quality of life measure favored cabozantinib nivolumab. And the reason is that if these patients are responding well, the complete response and partial response rates were much higher. The durability of responses were higher, and that leads to improvement in quality of life. So I think it's important. The choice of the treatment is really key here as well. And in terms of the baseline utility index, it significantly favored cabozantinib nivolumab as well. Overall, subsequent therapies, and again, remember, that's why you will see these curves merging as you go along. There's more subsequent therapies in sunitinib arm, more use of immune checkpoint inhibitors, because they have not been exposed to. Patients who are on sunitinib arm, they had not been exposed to. And again, that is where a huge opportunity is when you look at the sort of with this sort of a course that you have organized where people from across the country are taking part in that. If you start to merge that data, start to see how many patients are TKIs, how many patients then had immune checkpoint inhibitors, some of that real world data really can be huge addition to the literature that can come from Pakistan as well, inshallah, soon. So in terms of the follow-up, you look at doubling of progression-free survival with cabozantinib. I'm just use one of the examples to try and use that as a IO-TKI. It tripled the complete response rate, 4.6 versus 13.6, and half the progression rate, 13.7 versus 6.5%. So these are big figures. These make a big change in that. And the 23% reduction in risk of death with a hazard ratio 0.77 and median overall survival 46.5 versus 36. Tolerability was quite good. Quality of life was good. Toxicities were more. There were some immune-mediated toxicities as well. But remember, we have learned to use immune drugs much better now. The toxicity profile has improved in the real world than in clinical trials, actually, because we know how to deal with these, identify those toxicities and treat them early. So that is where I would like all the fellows and everybody to be more involved in these patients, whether you are mainly a urologist. I will still ask you to be more involved in oncology clinics as well, be involved in that. I don't know whether a rota can be done where basically these urology trainees can go into oncology once a week or twice a month or something like that. And the same will happen to some of the oncology trainees should come to urology when they are thinking of uro-oncology, because these specialties and these have to work in a multidisciplinary way. They have to work together like that. So in terms of, we saw about the multiple IO-TKIs, axitinib avelumab, axitinib plus pembrolizumab, lenvatinib plus pembrolizumab, cabozantinib plus nivolumab. And overall, you're seeing a benefit in those cases. Basically, overall, there is benefit in terms of the net health benefit when you're looking at these patients in this sort of a setting. So consistently, IO-TKIs do quite well. Cabozantinib nivolumab does come quite strongly, favoring that these patients do quite well with that combination as well. When I'm giving a talk, I'm always mindful of that. The cost of these drugs are phenomenal when you're looking at it in Pakistan, and availability of these drugs and affordability of these drugs are very important as well. But we'll be very happy to take questions and talk about it. In terms of the toxicity signals, when you look at the long-term follow-up, what changes is that you get, are there any new safety signals? When the patients are on it for 12 months or 24 months, what happens to toxicity and all that? So there were no new or unexpected safety signals. And the toxicity, again, can be well managed by using immune checkpoint inhibitor toxicity and treating them with steroids. Similarly, with cabozantinib, sometimes you do get significant fatigue. You can stepwise come down from 40 milligrams to 20 milligrams or alternate day treatments and things. So in terms of the discontinuation rates were lower then. And this is the way of increasing the exposure of the drug and improving the outcome for these patients. So in terms of the preferred over TKI monotherapy, these are preferred because they are much better both in ESMO, NCCN, and ASCO guidelines. And this is all for basically intermediate, high risk, and for across all IMDC risk groups. So highest level of recommendation is there, NCCN, EAU, ASCO guidelines strongly recommend all that. Immune-based combination, moving from second to third line TKI generation, when we look at and again, I mentioned about this Keynote XC Pembro, as you see, hazard ratio 0.84, more latest data, 40 months versus 47 months. And that is because patients progressing on sunitinib, then exposed to IO, there is a salvage, and the patient respond and maintain a long-term disease control rate, and that impacts on survival as well. And that is why I'm just a big proponent of the data that you have is the key. And if you bring that data out, look at the number of patients who had TKIs and then number of patients who could get checkpoint inhibitors. And there will be patients, unfortunately, who will not afford TKIs, checkpoint inhibitors as well. And those sort of things can be brought out in sort of literature. Key thing to look at, survival, 36 months versus 46 months. Overall, 4 years plus survival we are seeing with immune checkpoint inhibitors plus TKI combination. So as the data matures, the curves start to merge. And again, that, as I was saying, that overall good progression-free survival, durability of response, and the patient's quality of life is improving with all these different drugs. You are getting a good long-term follow-up in these cases. You are seeing in terms of real risk, real life patients as well now are being added on, and you can look at the real life data. And in terms of the early efficacy, you are seeing 16 months versus 8 months, 11 months versus 15 months, 9.2 versus 23.9 months. So different patients will have, in terms of median progression-free survival, big benefits. And similarly, overall response rates are quite high, 55%, 60%, 71%. Often the response rate translates into improvement in quality of life because the patient's disease is much better controlled. Their quality of life improves. They're more out and about. And I think those things are really important to look at because that has a big impact on patients' day-to-day living. Similarly, sort of treatment-related side effects are important, but discontinuation rates are improving because we are understanding how to manage these toxicities, and quality of life in at least one of those conditions, one of those studies was significantly better than sunitinib, and others were either no benefit, but still. So in terms of the guidelines, NCCN, you've got favorable axitinib pembrolizumab, cabo nivo, lenvatinib pembro. Other recommendations are ipi nivo, cabozantinib, axi plus avelumab. And in certain active surveillance can be used in favorable group or axitinib or high-dose IL-2. In poor, intermediate, axitinib plus pembrolizumab, cabozantinib plus nivolumab, ipi-nivo, lenvatinib pembro, cabozantinib. So you can see that the number of benefits and the number of sort of options that we have significantly improved. And again, how you choose those patients, carefully select what patient can have, what are the risk factors that are there with the patient, hypertension, stroke, any previous comorbidities, any other issues, making sure their blood pressures are well monitored when you're looking at these TKIs and second generation and third generation TKIs as we are moving into. So all these things are making a big difference. I just wanted to mention about the adjuvant treatment because there's a big debate going on. There's a 5% survival benefit that has been seen. This is a big paper from New England Journal of Medicine last year, April, which was showing that across the subgroup, there is benefit by using pembrolizumab in adjuvant setting. And again, across subgroup age, although more in sort of less and younger patients, because in over 65, it does cross the sort of hazard ratio, the 1 as the sort of a border there, but more in males. But overall, the benefit is seen in across all those subgroups of patients in adjuvant setting. And there is a reason I wanted to talk about it because there's a big question, because once you've used adjuvant pembrolizumab, would you be able to use when the patient progresses in metastatic setting, comes into metastatic setting, would you be able to expose them to immune checkpoint inhibitors as well? So we talked about overall survival benefit, but you're also seeing disease-free survival benefit significantly. And again, that is significantly improving it. And that benefit is there. And that benefit is across the subgroup of patients. So this is an important study. But what is the other factors to look at? 496 participants were assigned to receive pembro. And it's a big study, almost 1,000 patients. Median follow-up is quite 57 months. Disease-free survival, hazard ratio is 0.72. And significant improvement in overall survival, hazard ratio 0.62. So estimated overall survival is 91.2% in pembro group and 86% in the placebo group. It is important. In UK, we are very carefully looking at, although it is available now, but we very carefully look at the risk to some of those patients. We have had patients who had IO toxicity, who unfortunately had IO myocarditis and could not succumb to that. So there are toxicities with these immune checkpoint inhibitors. In the trial, very clearly with long-term follow-up, 86% was the overall survival. So there is a group of patients who have done amazingly well, and they have not progressed, for example, even with the placebo arm. And then when they progress, you've got the choice of immune checkpoint, IO plus IO or IO plus TKIs. So I would say one has to be very carefully look at, because pembrolizumab was associated with higher incidence of serious adverse event, if any, 20.7 versus 11.5. But very importantly is there's grade 3 or 4 adverse events related to pembrolizumab or placebo, 18.6% in pembrolizumab, 1.2% in placebo. Although no deaths were attributed to pembrolizumab therapy, but you can see grade 3 or 4 adverse event related to pembrolizumab of 18.6%. So that's a big number. So always be careful, because once you've used pembrolizumab here, and when the patient progresses, say in 12 months, how will you use your next treatment? Because IO may, in a sense, has already been used and the patient has progressed on immune checkpoint inhibitors. So one has to have a really strong, very, very open and frank debate with the patient. The risks should be discussed, the benefits should be discussed, and let the patient make an informed choice whether they want immune checkpoint inhibitors now, or would they want to see whether surgery in its own may well have cured them already and use immune checkpoint inhibitor if and when the disease progresses. So those are sort of debates as urologists you will have. And when you're referring the patients to the oncologist as well, it is important to talk about immune checkpoint inhibitors toxicity as well. Because when you're talking about an advanced metastatic setting where you're talking about a median survival of 24 months or 36 months, or maybe even 48 months now, the patient at least has a median sort of overall survival. We're talking about 36 months and 48 months. But patients in the adjuvant setting may well have already been cured by nephrectomy. So we need to be careful about these two different patient population group, those who may well have already been cured, and there's a 5% survival benefit at 40 and a sort of median follow-up of 57 months, 91% versus 86%. So one has to carefully look at the data, talk to the patient about the data, and then let the patient make an informed choice. So patient profiles, when you look at intermediate poor risk with sarcomatoid features, IO, risk of compliance issues, again, if side effects, then IO may be good. Rapid response is not the issue, because if rapid response is an issue, patient has got significant disease-related toxicities or disease-related factors, then IO-TKI may be better. IO-TKI is across all risk groups, good, intermediate, poor. In limited comorbidities, it has got a high CR rate as well. If rapid response is an issue, then it's always better to go for IO-TKI. Toxicity management issues will be important. When you look at IO, sometimes some of the toxicities are higher, but with toxicity in IO-TKI is quite different. You can get other class of, because both IO and TKI toxicity would come in there as well. One of the key factors is that once you've used both IO and TKI, when the patient progresses, then what will you use second line? Clear protocol for second line IO, because if they progress from IO, you've got second generation, third generation TKI still sitting there. So sometimes this is a way to talk to the patient and think about what could be the best treatment option for them, and let them make an informed choice, and help them make an informed choice in those sort of settings as well. So those are sort of the key factors that I wanted to really touch base with you. But important thing is that the preferred first line immunotherapy combo, challenging decisions are between IO-TKI versus IO, risk stratification, patient factors, response rates, ideal sequencing strategy still needs to be determined. And I think biomarkers are going to be the key, which are important for risk stratification and decision making. That will be very important in adjuvant setting as well. Shall we give it to all patients, or based on 5% survival benefit, we are seeing 86% versus 91%? Shall we look at some biomarkers that can help us to look at much higher risk patients? As we saw, younger patients had perhaps younger and much more high risk patients may well benefit more from adjuvant setting. But these are debates, and more clinical trials will give us more answers, and further ongoing trials are ongoing at the minute. So on that note, I will stop here, and very happy to take any questions.
Thank you very much, Professor Hussain. I think Professor Hamad was about to take a flight to Turkey for
All right.
something. Yeah, no, clearly, being involved in kidney cancer, I can totally understand and see how challenging this could be when we are encountering a high risk, high volume metastatic load in terms of using a combination and all. In terms of moving from first line to second line, Prof, I mean, let's say from a urologist's surgical perspective, what exactly the point you would decide that this is the time now to try the second line?
So I think when the patients are clinically and radiologically progressing, sometimes you do see some radiological progression, but I'm not worried about that radiological progression. Say some lymph nodes have grown from 16 millimeter to 20 millimeter. If patient is clinically well, they're still deriving benefit from immune checkpoint inhibitor. Remember that once you label the patient that they have progressed on that treatment, in a sense, you're closing the door to that treatment. You're moving on to second line TKIs. So just be very careful about trying to maximize the benefit from each line of the treatment. And that's what we use. But yes, if patient is clinically deteriorating, definitely there's a time to change, because patient has developed resistance to ongoing treatment. And with immune checkpoint inhibitors, we know as well, immune microenvironments may change, and that may lead to resistance to ongoing immune checkpoints. So you don't want to just carrying on immune checkpoint inhibitor treatment blindly. That's why radiology helps you. You do regular scans, but you also see these patients regularly. Clinically, somebody starts to lose weight, losing appetite, somebody who was really doing well and now comes back to you and says really struggling to play and go on golf or do anything else that they used to do and enjoy, this is an alarming sign, and you'll be doing a scan, which you do usually 3 to 4 months anyway, but sometimes I bring the scan forward. Sometimes a patient comes to you with falls or seizures, that this is perhaps brain mets now. So a lot of these factors which tells you where to stop with the ongoing treatment. The good news is that even if it's asymptomatic brain mets and thing, we are seeing some of these patients doing quite well. Sometimes even surgically, we have taken those mets out and carried on with IO treatment or some other treatment if lesions everywhere else is stable and there's a new brain mets. So kidney cancer is completely changed and transformed. What I'm delighted with Zishan and my other urology colleagues who are there as well, kidney cancer, bladder cancer, we are really fortunate to be in the arena of uro-oncology. Bladder cancer, I'm excited by everything going on. I'm involved a lot with NICE, and we are getting some more and more new drugs coming through. Kidney cancer is similar. FDA approvals have come through, but NICE is also keeping pace with all these approvals. To get adjuvant pembrolizumab, we were not sure that we will get it. I still am very, very cautious and careful about it, that we don't just use it for everyone, because it is not right for everyone. You can get early toxicity who may have already been cured by your surgery. So we need to be very cautious about moving from first line to second line. There are more and more options coming through. There are HIF inhibitors coming through now, which are being licensed and FDA approved. There is cabozantinib. There are new TKI inhibitors coming on the arena. Then there are new drugs coming in, which are looking at resistance, changing the resistance to immune microenvironment or changing the microenvironment to help with the resistance that patients have developed with immune checkpoint inhibitors. Or you can add another CTLA4 inhibitor. So a lot of the ways, and quite a lot of them are doing a biopsy at that point to see whether additional biopsy will tell you that resistance is being driven by some other pathway. So a lot of these things, which will be huge research arena and research point as well. But I really want to encourage everybody, Zishan, and again, you're involved a lot with my colleagues in Pakistan. I do a MDT with Pakistan once a week, and I see a lot of cases from Pakistan, and it's amazing the number of cases that they are, and the support and the treatments that are being offered in Pakistan is phenomenal. But what I really want you all and my colleagues who are there, I really want you to encourage to get more real world data out, so that people can see that actually what's the workload, what's the amount of cases you're doing already, and bring that data out. So it's not like I say or you say or Zishan say or Hamad says that it's a big unit and Khan does so many nephrectomies or cystectomies, but actually you print it out, publish it, present it at ASCO, ESMO, and EAU meetings to show that this is your workload.
Thank you very much, Rob. I think you emphasized on this in your last bladder cancer talk as well.
Yeah.
And I think probably at some point we would just connect outside a teaching session or a webinar and see how we could facilitate that. Certainly, that will be very
Yeah,
useful.
we'll be delighted to support in any way. Yeah.
Thank you very much. So I really hope everyone, it was a useful session on advanced kidney cancer and ERAS. And clearly some of these treatment modalities may not be yet available in Pakistan so commonly everywhere. But clearly, as a matter of time, like Professor Hussain has been so positive as well, our healthcare system will be moving as well. So thank you very much, everyone. I would encourage that these are slightly more tricky topics to always go back and look at the recordings when they're available as well, just to make the most out of it. And hopefully we'll see you again in 2 weeks' time. Thank you. Thanks a lot,
Thank
Prof.
you. Thank you very much. Allah Hafiz. Assalamu alaikum.
Thank you, Sharif. I think it's all done. Sharif, are you there? Just to do your recording thing, I just want to make sure that you capture all that.